Wellness Committee, I'd like to ask those members, the audience, to please have a seat so we can get this meeting underway. Thank you. Good afternoon, everyone. I'm Barbara Yaroslavsky. I'm chair of this committee, and I wanted to welcome you to the Education and Wellness Committee. I wanted to ask all of us to please turn off our cell phones, or at least turn them to silent and make sure they are off the table so we can avoid feedback noises. You may notice committee members accessing their laptops during the meeting. They are using the laptop solely to access committee meeting materials that are in electronic format. We have designated time on the agenda for public comment and ask for public comment on each agenda item. I ask that you be respectful of the need to conduct the committee's business. Should anyone disrupt the meeting, I will ask the person to conduct him or herself in such a manner that permits the committee to transact its business. This meeting will be available via teleconference as well. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconference process. For those members of the public participating via teleconference, please wait until the moderator has introduced you before you make your comments. To request to make comment during the public comment period, please press *1. You will hear a tone indicating that you are in the queue for comment. If you change your mind and do not want to make a comment, please press the # sign. Assistance is available throughout the teleconference meeting, and to request a specialist, please just press *0. The committee welcomes public comment on any items on the agenda, and it is the committee's intent to ask for public comment prior to the committee taking action on any agenda item. If for some reason I forget to ask for public comment or an agenda item you wish to speak on, please raise your hand and identify yourself on the phone, and you will be recognized. I would like to or recognized here in the room, I apologize. I would also like to remind all speakers physically present to complete a presenter's slip, so I may call on you by name at the appropriate time, and that record of this meeting can be full and complete. Please give your speaker's slips to Ms. Hawkinson. Ms. Hawkinson is right here at the front table. And if you're on the phone, just please identify yourself by name and the organization you represent. Each person will be limited to 3 minutes per agenda item. However, during the agenda item 3, which is public comments on items not on the agenda, the committee has limited the public comment period for individuals on the teleconference to 20 minutes. I'm going to see how it goes because, to be honest with you, we've got a tight agenda, full agenda, and we've got a time constraint. During the public comment on any other item, we'll probably allow about 10 minutes. After 10 minutes, no further comments will be accepted. Armando Melendez will be assisting me in receiving public phone calls from public. He's here somewhere, back there. Thank you. And I want to remind all speakers to please stay on topic. Ms. Hawkinson, would you please call the roll?
Yes, thank you. Ms. Yaroslavsky?
Present.
Dr. Krause?
Present.
Ms. Pines?
Present.
Ms. Shipsky? Thank you.
Thank you. The next, we're going to go to number public comments on items not on the agenda, item number 2. I don't see any slips from anyone present, and is there any comments from people on the telephone?
No comments from the telephone.
Thank you. So I'm going to ask for approval of the minutes from the January 29th, 2015 meeting of the Education and Wellness Committee.
Move approval.
Second.
Public comments on the agenda items. Any public comment from those in the audience? Any public comment from those on the telephone?
No comments from the telephone.
Thank you. So the motion has been made. We have a second, and all those in favor,
Ms.
please say
Yaroslavsky, I have to take a formal roll on that. Ms. Yaroslavsky?
yes. Aye.
Dr. Krause?
Yes.
Ms. Pines?
Yes.
Thank you.
Thank you very much. The minutes are approved. So we're going to now have a presentation on the updates on the Affordable Care Act and information on the physicians' compliance programs. Dr. Ashby Wolf, Chief Medical Officer of Region 9, Centers for Medicare and Medicaid Services, please come forward. Thank you. Welcome, and please start your presentation.
Thank you very much. It's an honor to be here. My name is Ashby Wolf. I'm a family physician, and I am the Chief Medical Officer for the Centers for Medicare and Medicaid Services, Region 9, which includes California, Arizona, Nevada, Hawaii, and the Pacific Territories. I've been asked here today to present some information regarding the Provider Compliance Program as authorized by the Affordable Care Act, and I'd also like to take just a few minutes at the end of the presentation to provide some updates on some key programs within the Act itself. So just to review, Section 6401 of the Affordable Care Act is the legalizing portion of the statute that provides details around provider compliance programs, which the intent of these programs is to assist physicians and other clinicians in appropriately providing information when they are billing Medicare and Medicaid or the Children's Health Insurance Program. There have been no new updates to this program since your last presentation in the summer of last year, but we'll review the key elements and talk a little bit about the published guidance that's available. And then last but not least, a review of a few programs of note as authorized by the Affordable Care Act, including some programs that are new that deal with value-based payment, and specifically a review of a new model that's out this summer that we're soliciting interest. And I'm happy to take questions, of course. Back one, there we go. Okay, so with respect to the provider compliance programs, again, I understand that information was provided to you about a year ago on these programs. There have been no new updates to the current guidance that is available. I've also been asked if there's an enforcement date on these programs, and the answer is no. We have not issued an enforcement date. Other than the one for nursing facilities who have their own provider compliance program, and their enforcement date was current as of March 23rd, 2013. The authorizing portion of the Affordable Care Act is Section 6401, which specifically directs the Department of Health and Human Services in consultation with the Office of the Inspector General to establish core elements for provider and supplier compliance programs within the health industry. Specifically, in order to participate or as a condition of enrollment in Medicare, Medicaid, or the Children's Health Insurance Program, physicians, their associated clinicians, providers of medical supplies must establish a compliance program to deal with proper claims billing, as well as ensuring that there is a minimizing risk when it comes to fraud and abuse. Again, an enforcement date for provider compliance plans has yet to be issued, but the Office of Inspector General has been providing guidance on these kinds of programs since the early 90s, in fact, when they began a major initiative to support healthcare professions in establishing compliance programs throughout their organizations and practices. The Office of the Inspector General has been working with the Department of Health and Human Services, advising providers, physicians, clinicians, and other organizations to voluntarily adopt compliance plans. And the Office of the Inspector General has issued several helpful guidance on this issue, specifically as it pertains to physicians, hospitals, nursing homes, pharmaceutical manufacturers, and physician group practices. Now, Section 6401 of the Affordable Care Act specifically addresses solo and small physician groups. However, the intent of the legislation is that all physician groups are in compliance. The guidance for these programs is published at the Office of the Inspector General website, and I'll alert you to some specifics here on this slide, where cms.gov we have multiple webinars as well as easy-to-use get-started guidance as it pertains to developing a compliance program and setting one up within an office or other entity. And just to put the importance of fraud and abuse in perspective, recoveries from the fiscal year 2013 totaled about $4.3 billion. And this is one of the major areas that the Centers for Medicare and Medicaid Services concentrates on in collaboration with the rest of the Department of Health and Human Services and the Office of the Inspector General. Again, the intent of compliance programs is to minimize the risk of practices as it pertains to improper billing and fraud and abuse. And these two websites serve as excellent resources in terms of guidance, products, and other information on compliance programs and getting it started. I believe that most health professionals are aware that there are compliance programs that are recommended for clinicians, but again, we don't have any enforcement dates specifically for physician programs at this time. As I mentioned, it's the intent of this legislation for all health professionals to implement a compliance program. And there are 7 core elements for an effective compliance program that are outlined in the guidance that the Office of the Inspector General provides. And again, there's been no new updates to this since you were last provided this information, but I wanted to go through each of the 7 core elements briefly to provide you some idea of what an effective compliance program includes. So number one, written policies, procedures, and standards of conduct. Obviously, establishing written policies and specific detail of procedures is necessary to promote consistency and uniformity in an office or practice as it pertains to proper billing and compliance. Certainly, this information, written policies, should be composed with the guidance of either an identified compliance officer or compliance committee. And details on how to set this up, again, is available on the Office of the Inspector General website as well as the CMS website. The second core element is compliance oversight of the program. And as I mentioned, identifying a compliance officer or a compliance committee who can oversee the program in some ways as an organizational watchdog to ensure that the policies are being implemented appropriately. Third, and one of the most important of the core elements, is training and education. Obviously, training not only the physicians, but staff and in the organization to be able to comply with the compliance plan, ensure that folks are aware of expectations and standards as they are written. Communication is the fourth core element, and clearly opening the lines of communication so that there are requirements for employees to be proactive if they see that something is amiss. Providing a formal process for managers to communicate compliance issues as well as results of audits or investigations, and a process to allow anonymous reporting without fear of retaliation. Fifth, the auditing and monitoring comprise the fifth core element of an effective compliance program. And this essentially provides assurance that the program is effective and ensure that it is in compliance with CMS requirements and to identify any risks to the organization. Ideally, the system should include a way to do both an internal audit for internal learning as well as an external audit if it may be requested by either CMS or the Office of the Inspector General. Sixth is the consistent discipline. With respect to when an investigation confirms that there is an offense, either improper billing or another form of fraud or abuse, it's important to have a plan in place to enforce consistent discipline. Written policies should be available for review from all staff and physicians, and it should be a plan that provides appropriate disciplinary sanctions on those who fail to comply with any applicable requirements. Last but not least, the final element of an effective compliance program is the use of corrective actions. If vulnerabilities or nonconformities are identified and or reported, either the result of a proactive staff member, an internal audit, monitoring programs, certainly consistent and corrective action must be conducted. Examples might include repayment of overpayments, disciplinary action against responsible employees, and the like. So specifically, what steps should physicians take? And this was, I believe, a question also that came up at the last meeting. Implementation of a compliance program sends a message that an organization or a practice conducts itself in an ethical manner and is committed to quality, not only from a customer service perspective, but from a patient care perspective. And so these four elements here provide some information about the steps that physicians should take in order to ensure that they have an effective compliance program. Again, the Office of the Inspector General has a specific guide for physician groups in all modes of practice, and the website is listed here, but I'm also happy to follow up with you through email if you would like additional references. This information, I think, is highly readable and easy to execute, and so I would highly recommend that people thinking about setting up a compliance program reference this document. Additionally, knowing where to locate easy and free resources is always a good idea. And this second point here with this second link, our HEAT team, or our Healthcare Fraud Prevention and Enforcement Action Team, provide compliance training for physician groups and other providers. And there are a number of really great tools that are easily accessible and available. Points 3 and 4 here are simply just general guidance. Obviously, keeping a plan simple and readable will allow it to be usable. And setting a date every year or twice a year to review a compliance program is always a good idea because it should be a living, breathing document that changes if circumstances around the practice or organization change. I'd like to also just briefly mention a few additional programs that are authorized by the Affordable Care Act, but that are in process of actually changing with the result of the passage of the Medicare Access and CHIP Reauthorization Act, which was signed by President Obama in April of this year. As you're aware, the Physician Quality Reporting System and the EHR Incentive Program, also known as Meaningful Use, has been in place for several years, since 2007. This year, the reporting year 2015, actually becomes very important for all physicians of all modes of practice. The reason is, if eligible physicians or their accompanying clinicians are eligible to participate and choose not to this year, they potentially face a negative payment adjustment of up to 7% of the fees they bill under the Part B fee schedule in 2017. So again, failure to participate as an eligible professional in this year, 2015 PQRS and Meaningful Use, results in a payment adjustment, a negative payment adjustment in 2017. And that is something that CMS is not authorized to waive that negative payment adjustment. It's authorized by statute. But I bring up these two programs because under the Medicare Access and CHIP Reauthorization Act, the Act actually made multiple changes, which will include some changes to the Physician Quality Reporting System and Meaningful Use. As you might be aware, the MACRA, as we're calling it, permanently repealed the sustainable growth rate, and in its place instituted a stable period of annual updates to the reimbursement schedule for physicians. That took effect July 1 of this year with a 0.5% annual update, and that will continue once a year, a 0.5% update to the fee schedule through 2019. In 2019, we, as the CMS agency, are required to implement what's called the Merit-Based Incentive Payment System, or MIPS, which is a combination of the Physician Quality Reporting System, Meaningful Use, and the Value Modifier Program. So while there are no regulations on this yet, we are working on it because Congress has asked us to provide a basic outline of how this MIPS system will work in early 2016. So certainly I'm happy to follow up with you all with respect to details as those regulations are written. And last but not least, the Regional Innovation Network is something that our region, Region 9, is trying through the Center for Medicare and Medicaid Innovation. The idea is to have CMS provide a platform for both virtual and in-person collaboration amongst physicians and other providers in the state. We had our first kickoff event in May, and our website, which is up and running, provides a way for people to connect and collaborate throughout the region. Since we're such a largely diverse and geographically diverse as well as ethnically diverse region, we thought that it might be a really interesting thing to try. And so certainly you're all welcome to visit the website, sign up to join our Regional Innovation Network, and certainly also feel free to contact me if you're interested. Last but not least, I wanted to call your attention to a new pay-for-performance model that's just been announced this summer. The reason I wanted to bring it up is because it potentially could become the way that CMS introduces future pilots and demonstrations. This is what's known as the Million Hearts Cardiovascular Disease Risk Reduction Model. And what it will do is it will test the concept of paying physicians for reducing long-term cardiovascular risk in their high-risk patient populations. The idea is to provide a payment incentive or bonus payment for prevention rather than specific process or outcomes like reducing blood pressure or LDL cholesterol levels. And so essentially what will happen is that there will be the predictive algorithm, the ASCVD calculator, which is approved by the American College of Cardiology and the American Heart Association. Beneficiaries and patients within different practices will be provided with their individual risk score, and over a period of 5 years, practices will receive bonus payments if they're able to reduce their beneficiaries or their patients' risk scores. An absolute risk score drop will be rewarded with a financial incentive. So it's something that I think is pretty exciting. CMS has never done anything like this before. But we are currently soliciting practices to participate. We're hoping to have about 300,000 Medicare beneficiaries, and that we're hoping about 720 physician practices are involved. So here's the website where we're soliciting information. There's also a lot of information about the trial design itself, but certainly you're welcome to contact me as well with any questions. And with that, I leave you with a few references. Specifically, this references the provider compliance guidelines, as well as details on the current value-based programs and the cardiovascular risk reduction model. And my contact information here, you're always welcome to contact me. And with that, I'm happy to take questions.
Thank you very much. Interesting presentation. Do I have any questions from Dr. Kraus?
Thank you for being here, Dr. Wolf.
My pleasure.
The recovery audit contractors are private firms contracted with CMS that receive a percentage of the payments taken back. Do they also receive a percentage when they discover underpayments?
So to be honest, I actually don't know. I'm happy to double check. That's one thing, I've been in my position since March, so that's one thing I haven't learned yet with respect to underpayments. So I'm happy to double check and get back to you.
Speaking as a member of the medical community, I know that many of my colleagues simply pay the RAC or let the RAC take the money back because their administrative costs in contesting would be greater than the amounts of money that the RAC is asking for. And I'm told that the letters which they receive whenever there's an adjustment include words like fraud. And I don't know that every overpayment is necessarily fraud, but I'm concerned as to whether or not that's also communicated to the physician's patients, that their doctor may be suspected of committing fraud. Do you know?
So the RAC is not authorized to communicate with any of the patients of the practices that they are evaluating or any of the hospitals that they're evaluating. And that's monitored very carefully by our policy and regulations committees and divisions.
Yeah. Certainly we do know from reading the newspapers that there are very egregious cases of fraud and abuse. I'd like to think that they occur at the hands of a minority of physicians and medical providers. But in my community, there's this underlying sense of fear and trepidation in dealing with the federal government and dealing with CMS. And I'm aware of physicians who intentionally undercode services in an effort to stay under the radar. Is there a way of CMS becoming kinder and gentler?
Well, I would say actually the fear of accidentally upcoding and so therefore undercoding so that you don't make that mistake. In that situation, you're not really getting paid for the value of the work you're providing. And that's one of the reasons I would say to actually develop a compliance program for the practice, because it will provide information to any external auditors, including CMS or the Office of the Inspector General, that there is a plan in place, that it's clearly written out, that people are proactively evaluating what we're doing. And certainly the intent is not to go after every accidental upcode. The idea is to ensure that there's not a systemic process to defraud the federal government. And so having a compliance program in place, even a basic one that's structured on the guidance provided by the Office of the Inspector General, I think is actually a great way to protect the practice and to ensure that you're actually getting paid for the value of the work.
And I must say that the electronic health record has been a help. Because most of the software in the electronic health record lets you know what the proper level of coding is for the service provided. On the flip side of that, there have been some electronic health records that prompt for additional information or sometimes even cut and paste additional information. And as a medical board member, it causes me to worry as to whether or not the medical record we review becomes an accurate representation of the service that was really provided on that day.
Well, certainly with respect to cutting and pasting, that certainly has potential to provide inaccurate information. So active documenting in real time is always the best idea.
Thank you for coming.
My pleasure. Thanks for having me.
Ms. Pines, any questions?
No questions.
I just have a quick question, and that is, given, unfortunately, there is the occasion of waste, fraud, and abuse, some of it being unfortunate, really unfortunate. Is there a mandatory reporting or an expectation that those individuals are reported to the medical board? Should there be? Can there be? Is there?
I don't believe that there is. I will have to check with our legal Office of Legislation to see if there is a statute that directly addresses that. And I would say I'm not sure if there should be.
Yeah, I
or
think it'd be
not.
interesting, then maybe you can get back to the staff on that, I'd be interested. Thank you again for your remarks. Are there any public, Dr. Hawkins?
Thanks again for the presentation. We anticipate that ICD10
Wait, you need to come to the microphone, please.
And we have to check for a quorum, doctor, before you speak.
Thank you very much.
It's okay? Please, go ahead.
So we anticipate that ICD-10 will occur actually in October. It's been late a couple of years. Do physicians need to worry about this new system of coding and billing will have an adverse effect on scrutiny just because it's a new system, it's more complicated, involves more level? What can we anticipate that? And is CMS willing to give doctors a little bit of leeway as we discover how to use this system?
Thank you. That's an excellent question. So actually, the Medicare Access and Chip Reauthorization Act was, there was some thought that there might be a delay in ICD-10 implementation in that act, but there was not. So the active date is currently October 1st, where we expect the ICD-10 to be up and running, so to speak. However, about 3 to 4 weeks ago, we at CMS, in conjunction with the AMA, actually issued additional information about the first year of ICD-10 implementation, specifically that providers will not be penalized if they get the incorrect ICD-10 code, as long as they're within the correct ICD-10 family of codes, so that there will not be untoward penalty for physicians who are using the system in a brand new way. And there is specific information as well as actually a person that will be designated as the ICD-10 ombudsman, who will be responsible for triaging physician issues with the implementation of ICD-10 after October 1st. And I'd be happy to send that to the medical board so
Thank
that you
you.
can issue it.
Okay, thank you very much for your presentation. Let me just make sure there are no questions on the phone.
No questions from the telephone.
Thank you. Thank you again.
Thanks very much.
So I'd like to move on with the agenda and ask for Dr. Schola to come forward. Dr. Schola is going to present on the trauma-informed care and the impact on long life health. He's an associate professor of clinical psychiatry and the medical director of Northgate Point Regional Support Team at the University of California, Davis. Thank you very much for being here. If anyone is, the bio is in the packet, so I'm not going to go through your bio, so no offense, it's okay. So please.
Thank you very much. Good afternoon, everyone. And it's really an honor to be here to present to you this topic that I believe its time has come. And I will go over essentially two issues. One is the why this is important, and the second is how to address this in terms of physician competence to address the health and improve outcomes, health outcomes of patients with history of trauma. So these are the two objectives of my presentation. I will provide a brief, very brief overview of a topic that is very large, and unfortunately there might be several issues that I don't have time to take questions and clarify. But most of the bullet points about the first objective, the overview of research, is backed by literally hundreds of references behind that. So these are conclusions based on multiple lines of evidence. And the second objective of this presentation is to propose, advance an approach based on something that we already are doing, things like cultural competence and patient-centered care, especially communication skills that can enhance outcomes by being patient-centered. So this is a quote from a paper from one of the leaders in psychiatric research. He's Dr. Avshalom Caspi, who's one of the pioneers in the world of the so-called gene-environment interaction. And he is saying here, childhood maltreatment appears to be a risk factor in the history of patients having many different psychiatric outcomes. Indeed, it is more difficult to identify a disorder to which childhood maltreatment is not linked than to identify a disorder to which it is linked with specificity. Probably many of you will not be surprised by this finding on this statement, but let me move on and show you something having to do with physical health. This is a graph of a study, a recent study from the Nurses' Health Study, a large longitudinal study of health outcomes. And you see here the black line at the bottom of the several lines here, showing that over years, the incidence of diabetes increases steadily. But what it shows here too, these other color lines, is that even people with trauma history but no symptoms of PTSD have an increased risk for developing diabetes. So one of the first conclusions of this kind of research is that post-traumatic stress disorder is really like a tip of an iceberg. The behavioral and health manifestations of trauma are manifold and are not encapsulated only by PTSD, and not only by mental health issues, but by physical health. In fact, non-communicable medical illnesses, the main killers of people in the nation, are all related to history of trauma, especially trauma that happens early in life. So to illustrate this point, imagine that this axe is cutting, this axe is trauma that can happen at some point in this tree of development, and the sequela, the consequences of this cut, is going to be different depending on how close to the trunk or how distal, if you will, to the trunk this trauma happens. When you have the so-called childhood adverse experiences, these experiences happen very close to the trunk, when the body and the mind are just starting to develop. So the consequences are long-lasting and manifold and very varied in behavioral and physical manifestations. So this is one study, a hallmark study, the so-called Adverse Childhood Experiences Study. This was conducted a few years ago by Kaiser Permanente in San Diego, and they involves over 17,000 patients at Kaiser Permanente, and they measure 10 adverse childhood experiences, and they develop a score going from 0 to 10. And you can see here in this particular graph is the number of adverse experiences increases the odds ratio, the likelihood of someone developing heart disease after controlling for all the imaginable confound factors, the other explanations such as smoking, even depression and obesity, etc. So here you have this, what in medicine we call a dose response curve. The more adversities, the risk of heart disease increases steadily. This graph can be replicated dozens of times with different outcomes. The Kaiser Permanente ACE study with funding from the CDC looked at tens of outcomes, and the same kind of relationship was found. Now, the ACE study has been replicated at the state level, not with patients, but now with the general population in many states, including California. And so in California, we know now by county, we can assess the prevalence of the number of ACEs in various populations. And so we have this data, and let me summarize now other kind of data that strengthen this point that I'm trying to make. Trauma exposure across the lifespan is associated with increased morbidity and premature mortality. In fact, in the ACE study, the original ACE study, those people who had a score or 7 or more were more likely to die prematurely by 20 years earlier. 20 years. The trauma is associated with treatment-resistant chronic conditions. This is especially well studied with psychiatric problems, depression, PTSD, anxiety disorder, substance use disorders. Health risk behaviors. This is a very important point because there's not only data that shows that trauma, especially early life trauma, is associated with changes in the biology that predispose to these chronic illnesses, but it's also associated with behavioral adaptations that individuals develop that later in life become problematic, such as smoking. Individuals also with history of trauma, very often trauma early in life has happened within the household with individuals who you're supposed to trust as a child, and you're vulnerable and helpless, is associated with increased distrust of healthcare systems and providers. You can also imagine that this distrust is compounded in certain groups that are traditionally stigmatized or disempowered, such as women, people of color, sexual minorities, people of lower socioeconomic status, immigrants, lower educational attainment. Trauma exposure is also associated with increased sensitivity to power differentials and authority figures. So this can play a role very much so in encounters between individuals such as providers, physicians, who are traditionally conceived as someone in position of power. And not surprisingly, the so-called difficult patients are overrepresented among those with history of trauma, especially early trauma. So these individuals will have difficulty engaging in preventive care, which requires steady adherence to medications, frequent visits, and so forth, in addition to access. We'll not talk about access to health care. They also are more at higher risk to develop comorbidity of behavioral and physical health problems, including substance use disorders. So what are the implications for clinical care of this research? Since trauma is so prevalent across the lifespan in the general population and clinical settings, it's important to note that research has shown that trauma survivors want to be asked about their history of trauma by their providers. There's anonymous and non-anonymous research and surveys of patients to underlie that point. Now, this is a tricky statement, perhaps. I'm saying that for many patients, disclosure of traumatic experiences is therapeutic in itself. But of course, it could be re-traumatizing if it doesn't happen with an attentive, empathic ear. But for many people, when there's disclosure happens with a trusted health provider, a physician who is empathic, this can be enormously healing and therapeutic on itself. Now, an important part of this is that many patients, perhaps most patients, are not aware of the connection between ACEs and their current health problems. We as physicians know that, and we can educate our patients. So we can empower them. And many patients become enlightened, if you will, and feel relieved. Now they understand why they have this kind of problems they have, especially behaviors that are self-destructive and puzzling to many patients. Why do I keep falling in the same kind of relationships? Why do I keep doing things that I don't want to do? So trauma-informed care requires excellent communication skills, because of these issues that I outlined before. And some of the challenges to implementation of this trauma-informed care are perhaps billing procedures that, because as I will point out in the following point, TIC, trauma-informed care, works best when care is collaborative and integrated. So some of the billing practices might need to be modified. So we also have a challenge as I'm a medical educator, and I see this very clearly, that we need to educate the new generation of providers in interprofessional settings, but also physicians and medical students. And at UC Davis, I'm proud to say that we're innovators in the field, and we're doing that already. The other advantage that I see in trauma-informed care is that it fits naturally with cultural competence, which is something that we're already practicing and continue to improve. Trauma-informed care is congruent with interprofessional practice, in fact, thrives with interprofessional practice. TIC works synergistically with the ACA Affordable Care Act supported patient-centered medical homes. So there's an opportunity to implement this. And also, very importantly, trauma-informed care takes into account social determinants of health and is aligned with the goal of eliminating health disparities across the nation, and of course in California. So I'm going to close my presentation with, sorry, I apologize, with a proposal of what I think a practicing physician or graduating physician should look like in terms of competence regarding trauma-informed care. So a physician should be able to regularly elicit history of exposure to traumatic experiences. And of course, the physician should be able to adjust this to a setting or the type of patient. A child with a caregiver or a family, among them could be a perpetrating of abuse or trauma, the race, ethnicity, socioeconomic status, etc., characteristics of the patient. The physician should also respond with compassion, normalization, and education to patient disclosures. A physician, a competent physician, should be able to identify and advocate for resources in the community and or in the same setting and refer those patients to appropriate services. The physician should also be able to elicit and identify patient strengths, life goals, and values that can sustain recovery, because this is a lifelong endeavor for many patients. So they need the physician, in order to support the patients, need to have an idea of what is important in the lives of patients. And most importantly, the physician should integrate the information they have gathered about trauma and resilience in treatment plans that are culturally responsive and patient-centered. With that, I conclude my presentation. Thank you.
Dr. Scholler, thank you. That was really, really interesting. I appreciate your presentation today, extra. It really resonated with me personally. Any questions from people on the committee? Dr. Kraus?
Thank you for your presentation.
My pleasure.
Do you find similar problems in children who witness trauma but are not necessarily the recipients of trauma?
Absolutely. Yes. One of the main findings of this research, the neurobiology of stress, is that it doesn't matter what the stress is. The final common pathway is the stress response system in the organism, and that system is blind, if you will, to whether you are a recipient or witness of trauma.
So in that sense, then, would you say that the physician should also inquire about the domestic situation and even the neighborhood situation in terms of neighborhood violence?
Absolutely. One of the limitations of the original ACE study is that this was a study conducted in mostly white middle class, privately insured patients, and they didn't consider other determinants of health, such as community violence. And newer version of the ACE study, for example, in Philadelphia, are very much considering those factors.
Thank you.
Ms. Bynes? Any questions?
Yes. Do you see ACE increasing, and do you see more incidences, so more increased adversity? So first, is it increasing, but if it's not increasing, are there more incidents increasing?
It depends on the location. The data that we have is that in some locales, because of concentrated poverty in urban settings, very much so, there are, for example, epidemics of violence. And unfortunately, I didn't talk much about this, but there's also studies that show there's a transgenerational transmission of trauma. The first person to study this was Dr. Rachel Yehuda in Mount Sinai, New York, who studies survivors of the Holocaust, the Jewish Holocaust in Europe. And so we know now that some abnormalities in the stress response system can happen in generations after that were not exposed to trauma. Did I answer, I'm sorry, did I answer a question?
You did. And then just the recommendations that you're making for physicians, in the time frame that a general physician has to see someone, 15 minutes maybe? I mean, how, when they feel maybe they've encountered someone who's had a traumatic experience and yet in 15 minutes I can't solve that or help them move through that, what are you really suggesting?
Thank you for the question. That's a very challenging question, and it's very, I'm working with other colleagues right now, actually in partnership with people across the nation, because that's a real challenge. The short version of my answer to that is that physicians need to approach this issue like you would approach someone who you recently today diagnosed with diabetes and they have high blood sugar. You're not going to change the problem right there. You are going to start building a therapeutic alliance, a trusting relationship with someone that maybe never has trusted people before. So it's very important that it doesn't need to be very ambitious the first time, but so this is particularly important in primary care settings where you can have the luxury of establishing hopefully long-term relationship of trust and respect and collaboration with patients, which by the way are the tenets of patient-centered care that can lead to improvement and changes in lifestyle when you treat patients with respect and empower them.
Mm-hmm. Okay, thank you.
Thank you again. Are there any questions from members of the audience? Seeing none, is there anyone on the phone?
We have no comments from the phone lines.
Thank you again, Dr. Scholla. Dr. Hawkins, wait, Dr. Scholla, I apologize, Dr. Hawkins, and I just would,
Yeah, we do have to check.
you have to check for a quorum, and we also have to check on the time. You're okay. Dr. Hawkins, please.
Thank you. Just a brief comment, and thank you for this presentation. I would just like to amplify what's been stated. In my own practice as a lung specialist, sometimes we have those patients that are very, very difficult to treat. We've gone through all the levels of evaluation and treatment. We just don't seem to get there. And more often than not, sometime later, sometimes 6 months, sometimes a year, sometimes longer, we find there's an underlying thing, maybe it's trauma, that really has been there all along that's gotten in the way. And sometimes it just seems to take time to get there, but I think you answered the question in part, how do we sort of get there? We're obligated to do the things we would customarily do and not make that the first thing you go to. It's the trauma. No, it's just, maybe it's you're not taking your medicines or something like that. Just a brief comment.
Thank you very much. Thank you again. I'm going to ask if there are any future agenda items that members of the committee would like to hear about.
Pass.
Pass. Well, let's think about that, and let's get back to staff in the next couple weeks. I'd appreciate that. And with that, I'd like to thank everyone for being here today, and I would entertain any comments from members of the public? From the phone? Thank you. Apologies.
Move adjourn.
Thank you very much. So moved and seconded, and we're finished. We're going to meet back here in another 7 minutes, actually 5 minutes according to my phone, for our general medical board meeting.